All right, sweet. So let's go ahead and get started with blood and circulatory system, part 5, medications. This is the way the PowerPoint is structured. Again, is you've got all your disease processes and foundational information and concepts at the beginning, and then I save the meds for the end. The reason I save the meds for the end, which is completely different than the way I've run it before, is the meds are commonly given for multiple disease processes. So when I would organize the PowerPoints previously, I put the meds with some of the diseases that they were most commonly used for. But then I had some students who were struggling to make the connection of, well, couldn't they be used elsewhere? Absolutely. So one way to kind of get rid of that maybe miscommunication or misunderstanding was to just put the meds at the very end, and then we can talk about them in terms of how many different disease processes they might go with. And even then beyond this PowerPoint, where else might they be utilized? So first medications we're going to talk about involve anticoagulation. So warfarin, heparin, the arin ending drugs. Warfarin is an oral medication that most commonly is connected with the INR. And I know we talked in class about PT, PTT, and the INR. So warfarin goes with INR and PT, but most commonly we're just looking at the INR. And anytime you have a medication that has a lab value, you need to be thinking, is there a normal value, which most medications, if you're not taking it, then it's not in your system. However, the lab value for warfarin is something that you normally have in your system. The INR is, there is a normal value for that. And you could even narrow it down to be like, it's kind of 1, the ratio, the INR, which is international normalized ratio, but it's kind of real close to 1. And then when you're on warfarin, and anybody want to tell me in the chat window why you take this? What would be a reason for taking warfarin? Right, blood clots. Now, is this drug, from what maybe you've studied already, is this drug a drug that is used and acts quickly in the body, or does this take time to work in the body? Yeah, it takes time. Anybody want to take a shot at how long it takes? 3 to 5 days. So what do we do in the meantime? Because if somebody has a blood clot, that's a life-threatening disorder, problem, and we need to do something quickly. Heparin, excellent. So does that mean that they're going to be on it at the same time? They're going to be on warfarin and heparin at the same time. Yes, they're going to be on it at the same time. How do we know, and we'll get to this when we talk about the heparin, but how do we know when we no longer need to be on heparin? How are we going to know that we no longer need to be on heparin? Therapeutic level. Which one? When the INR is in therapeutic range. So, right. So if you're on warfarin and your INR is 2.2, you don't need to be on heparin anymore. If your INR is 1.4, you would still need to be on the heparin until that INR reached therapeutic level. And if it was 4.7, what are we going to do? We're probably, we don't need to be on the heparin anymore, but what does that also mean? INR is 4.7. Now this is somewhat of an ordering process. You are never going to give an antidote until you do what first? we're going to stop the warfarin, or in this case, we're going to decrease the dose of the warfarin because obviously the dose we're giving them is too much. So we'll decrease the dose. 4.7, you may or may not need vitamin K, but you hit like 6, 7, 8, heaven forbid, you start getting up into that range, then yeah, we'll probably stop the warfarin for a few days, give them vitamin K, and then deal with them from there. Now, as far as diet goes, we talked about this in class. You don't stop taking vitamin K as a diet, as your foods. You just maintain the dose, maintain the vitamin K intake, maintain those food sources that you're normally doing. So if you change your diet, you need to also do what? If you're like, I'm thinking about changing my diet, like kind of long term, what would you, you want to talk to the doctor. Excellent. And anytime you're on a RIN drug, what are you watching for? Bleeding, because that's what it sort of causes. So we want to watch for that. And you can go back into the slides where it talks about bleeding. Now, warfarin interacts with a ton of drugs, a ton of foods, obviously for the vitamin K purposes. But I put on this slide, some drugs decrease the anticoagulation effect, means you're at risk for clotting still. So a lot of your seizure drugs, which phenobarbital is a seizure drug, phenytoin or Dilantin is a seizure drug. Now birth control warfarin can maybe decrease birth control's effect, but also birth control can kind of decrease the warfarin's effect, and then obviously vitamin K. On the other side, you've got an increase in anticoagulation effect, meaning these are going to jump the effectiveness of your warfarin. So you're going to need less warfarin if you choose to stay on those, or let's not be on those drugs. So we can just balance out the INR level for, again, that therapeutic range while we're on the warfarin. And then there's heparin. Heparin is sub-Q, it's IV, whereas warfarin is oral. So heparin is much quicker absorbed into the bloodstream and deals with the lab value much more rapidly than what warfarin deals with its lab value. Now, the lab value for heparin is PTT or APTT, which is approximated or estimated PTT level. And the numbers are relatively close. It's kind of like, how do you estimate 104? Well, it's about 100. That kind of thing. How do you estimate 42.1? Well, it's 40-ish, or even, getting closer, but it's an approximated, but fairly similar numbers. Now, again, your body has a normal clotting time. A normal, no medication, 25 to 35 seconds is about the range. 30 to 40, 25 to 35, somewhere in that range is what you and I have, at least if we're not on heparin and I'm not on heparin. Now, if I'm on the medication, I want a therapeutic value, which is going to be 1 to 2 times the normal, which you just double it. So 1.5 to 2 times. So somewhere in the 45 to 80 second range, 40 to 80 second range. Now, again, if you're not on heparin, we want to have that normal value. If you're on heparin, we want that range to be 45 to 80. If you're 30 while you're on heparin, we need more heparin. If you're 90 or 100 or 120, then what would be the things we need to do? If you had somebody on heparin, they're sick and they do these every 6 hours, like the slide says, they're 112. What would be some things that the nurse would do at that point and try to prioritize it? What would be the first thing you conceptually would think about doing? PTT of 112. So yeah, conceptually speaking, Kayla, you're right. We want to lower the dose. We want to stop the drug temporarily. A lot of times when somebody's on heparin, we want to there's orders to just readjust the dosing. We don't necessarily want to completely stop it. We want to decrease the dose, see if how much that helps or affects that PTT level. Excellent. We want to watch for bleeding. Now, if there's no signs of bleeding and they're 112, we probably don't need to stop the drug. We just need to back off of it, or stop it temporarily, per whatever orders, or talk to the doctor and get those orders. It's when you have signs of bleeding that you're probably going to stop the drug and give the antidote. So we don't necessarily need to give the antidote as soon as somebody is outside of therapeutic. The antidote is really saved for somebody is having extreme symptoms of that elevated lab value. So with warfarin and INR, we don't really need to do vitamin K until they are showing serious signs of bleeding and their INR is really high. We don't really need to do the antidote protamine sulfate for heparin until their lab value is really high and they're showing signs of bleeding. Other than that, we just sort of decrease the dose, stop it temporarily, readjust. And that's where this is coming from. So really only if there's that imminent danger with the signs and symptoms pointing to the concern of bleeding, do we really need to consider giving that antidote. Here's a couple other ones. These are low molecular weight heparin. So enoxaparin is a common drug that you'll probably see in practice. It looks like it's in a syringe like this. It's pre-filled. Now, what do we do with that? Anybody ever administered enoxaparin yet? Cool. What do you do with, how do you pull it out, you open up the package, it's pre-filled. What do you do next? Clean the site and administer. Okay, you're missing a step. It should already, you don't have to worry about it being primed because the needle's really, really small. Yes, you want to check the lab, which in this case, enoxaparin's lab value is more platelets, but don't worry about that right now. Don't have to worry too much about the lab value on this. I'm looking more at the administrative aspect. What do you do with the bubble that's there? So here's where it's a little different. If you get rid of that air bubble, you risk getting rid of a little medication along the way, and you risk having a little bit medication left in the syringe after you administer it. So you actually want that air bubble that's already there up by the syringe plunger like it is in this picture, and then you administer it like that. So you turn it so that the plunger is up top, you kind of flick it a little bit so the air is at the top, and then you administer it. You actually want to leave that air bubble there. Because remember, we're giving this sub-Q. I'm not worried about giving an air bubble into your subcutaneous tissue. It's when you administer an injection into the IV that it can be a problem. So in practice, I actually leave just a little tiny air bubble in my sub-Q injections, in my IM injections, like vaccines and stuff like that. I'll leave just a little tiny air bubble near the plunger. And I'm saying little tiny, like 0.1 or smaller than 0.1, so that when I inject it, I know that all of that medication is going in. Plus, if you Z-track it on an IM, it kind of airlocks in there too, which is good. Your IV meds are the ones that you don't want air in. Those are the ones you really get rid of. Antiplatelets, you've got aspirin, you've got Plavix. Aspirin has its own risk of Ray's syndrome, which, does anybody know anything about Ray's syndrome? Who is that involving? What is the issue? Happens in children, yes. So you don't want to give aspirin to people, kids under the age of 2, but it's even safer if you don't give it to kids under the age of 6. Now, can anybody come up with the problem with Ray's syndrome? Like, what's the big deal about Ray's syndrome? Yeah, you could really just say it kills them. I mean, it affects the liver, it affects the brain, it causes seizures, loss of consciousness, convulsions. Now, they typically need a pretty decent dose of aspirin in order to get it, but we're just not going to test that out. So we want to keep that away from them. Indications and uses for antiplatelets. Remember, antiplatelets work on what blood vessels? Arteries. Good. Anticoagulants, warfarin, heparin, work on vessels, the veins, and then antiplatelets work on the arteries. And then the other thing is there is no antidote. So this is why some people use it to commit suicide, because once it's absorbed through the GI tract. Now, so if you take a bottle and somebody finds you and you get rushed to the ER, then we're going to give you like charcoal to sort of like bind with that aspirin and hopefully just poop it out. But if you don't get that aspirin bound to something, it's called chelation. You don't get it bound and pooped out, then it gets absorbed into your bloodstream, and that's where you have major problems of bleeding. Other side effects, adverse effects. I do want to mention with side effects, adverse effects. On my slides, I try to make the adverse effects bolded and underlined, and then the side effects just normal font. And the reason I do that is I want you to see what is life-threatening and what is not. Now, I'm not perfect on those. Sometimes it's in between. It's not really a side effect. It may not be an adverse effect, but I try to do my best to kind of draw that out because there is a difference. Side effects are things that you just sort of deal with. Maybe a big deal, maybe not a big deal, versus life-threatening problems. Now, if a question asks, not just my class, any class, the NCLEX, a patient, a family member, what are the side effects of this drug? Are you going to give them the normal stuff, or are you going to give them the ones that are going to kill them? Yeah, we're going to focus on, I mean, if people's attention span is very short, we want to make sure we use that attention span well. So we're not going to waste our time with, it might cause nausea and vomiting and diarrhea, and you might just feel a little fatigued. Okay, don't waste your time on that. It might be true, but you want to spend your time focusing on what are the adverse effects, what's going to kill them with this drug. Contraindications, obviously, if you already have bleeding disorders, Antiplatelets, because of how they work on the gastric lining and a part of the protective mucus of the stomach, you do not want to give antiplatelets or NSAIDs. You don't want to give NSAIDs to people who have peptic ulcer disease. It's a no-no. You don't want to give steroids to people that have peptic ulcer disease either. And then thrombocytopenia is if you already have low platelets, we don't want to give you a drug that affects the platelets any more than they already are. Now, here's the thing. When you give an antiplatelet, you're not worried. The lab value is not what you're focused on. It's the effect on the platelets. Antiplatelets don't change the value, the number, so it's not going to make you lower in a platelet count. What it does is it makes the platelets slippery, so they slide by each other, which is why they can't form a clot, which is why you can end up bleeding from it, because now the platelets just they're not working. So it doesn't change the level, it changes how they function. Now we get to drugs that actually stop clotting and they break clots. So thrombolytic drugs, the ending, ACEs, alteplase, and you could honestly come up with whatever drug name you wanted. Amikamines, like the ACE ending, Teleplase is another drug. So these ACE endings are enzymes, and these enzymes actually eat up a clot. They actually destroy the clot that's there. But they only work if you give them fairly early in the process of that clot forming. So really what happens when you form a clot is all these elements come together and they sort of form a cement. So if you pour cement for a driveway, you only have a short time. If you go, oops, I made a mistake, to sort of fix that cement before it hardens. That's kind of how these drugs work. If you're like, oh, we have a clot forming, we need to give a medication that breaks that up before it actually solidifies. So we only have typically about 12 hours. They say the earlier you give these medications, the better, obviously. The earlier you address the problem in the cement, the easier it is to fix it. The longer it's set, the harder it is to address it. So these drugs break up clots and they stop clotting. So can somebody tell me, what is our why don't we give these more often? What, I mean, if they're so amazing at dealing with clots, why don't we give them more often? Yeah, excessive bleeding is the risk. You can bleed out. So these drugs can kill you, but if you have a clot that's already killing you, then we need to try and deal with it. So it's this give and take of at what point is the benefit going to be outweighing the complications. So we really, really need to watch for bleeding. And then we need to watch for cardiac dysrhythmias. And yeah, it might cause some hypotension, but not really that worried about it. And even the hypotension is probably coming from the fact that when you gave this drug, the person had been bleeding, or who knows. So there could be some other issues in there, but bleeding is the biggest concern. So if you already have a history of something that could make you at risk for bleeding, we don't want to give these drugs, because then they really do have a greater risk of killing you. And again, interactions. These drugs kind of are given alone. We don't want to give them with warfarin. We don't want to give them with heparin. We don't want to give them with, NSAIDs that affect bleeding, or your aspirin that can affect bleeding. We really want to be careful about what we're giving them with. Now you have to change your mind. We're going to the other side of the problem. Anti-fibrinolytic drugs, meaning against breaking down clots. So these actually help you clot. These are drugs that are given to help you deal with bleeding problems. So clotting we've already dealt with. These are to deal with bleeding. So things like hemophilia or major hemorrhage, or or an antidote for the thrombolytics, because maybe we gave you the thrombolytics and then you start doing that severe bleeding stuff, and now we're worried about you dying from bleeding, and we need to give you something that's going to stop that process, stop that bleeding. So we can give you an antidote for it, or the desmopressin is for factor VIII hemophilia as a replacement. So a few slides here, just overall nursing implications for these drugs that are dealing with clotting and bleeding. You're watching lab values, you're watching signs and symptoms of the bleeding. And if you're doing that, you also want to teach your patients how to decrease their risk of bleeding. So wouldn't encourage somebody who's on warfarin to play football. Going to use a soft toothbrush, going to deal with an electric razor. I think I need to shave tonight before I go to work tomorrow. I'm on aspirin, so I do worry about bleeding a little bit, but it's not like if I was on warfarin or heparin. Those really, I mean, you're holding pressure to that site for a long time if you cut yourself and you're on warfarin or heparin or something like that. So we want to decrease the risk of that. A lot of people, if they're on those drugs, are going to have a medical alert bracelet because of, again, that risk of bleeding, the risk of drug-drug interactions. And before you start anything new, we got to talk to the doctor. So now some other drugs. Iron. I wanted to talk briefly about iron. Mentioned it in class with the iron deficiency anemia, that if you have iron deficiency anemia, you give iron. So we talked about, I think we talked about the straw already, and if it's liquid for taking it orally, we need a straw. If it's an IM, we need to Z-track it, because this stains tissues. And you notice that there isn't a whole lot of adverse effects. Oops, I didn't mean to do that. But we do worry about constipation. We worry about changes in stool, because it might just be the iron, but what also could a green or black darker color stool signify? Couldn't signify bleeding. So, and we're giving iron because their red blood cell count is low. Well, why would a red blood cell count be low? Because they're bleeding. So we want to, it's a normal side effect, but we also want to make sure we're watching for the bleeding issue as well. Here's the tricky part. Iron is best absorbed on an empty stomach with some fruit juices, orange juice. Make your stomach more acidic. But it also gives nausea and vomiting and diarrhea and gastric irritation. So a lot of people are encouraged to take it with food. Now, if we're taking it with food and it's not absorbing as well, we just need to watch their lab values to see if it's having the effect that we want. Watch their H&H, watch their red blood cell count. Maybe we need to increase the dose of iron because they're taking it with food. That's all on a patient-to-patient basis. And then there's epoetin alpha for severe anemia. Now, this is synthetic erythropoietin. Now, what is erythropoietin? What does erythropoietin do? I think it was mentioned. It is produced by the kidneys. Excellent. Erythropoietin, what does it do? it stimulates red blood cell production. So it goes to what tissue to there we go, Andrew. So it stimulates the bone marrow to make more red blood cells. And I think I mentioned this in class too, that there's a problem with epoetin, with the administration of it. What did I mention in class that you want to be really careful about when you give this drug? So when you're answering a question about a drug, stay close to home before you go looking down the yellow brick road. You want to stay close. So EPO creates red blood cells. So what would be a problem? Too many red blood cells. That's all it's asking for. So EPO, actually, you want to stop giving it when. So if somebody's really low and we're giving them epoetin alpha, when would we want to stop giving this drug? We're going to watch a lab value when they're almost normal values, right? Fair enough. We don't want to wait till they're normal. We want to stop early. So you want to stop when their hemoglobin's around 11 or maybe even a little bit before. Otherwise, you can end up with complications of too many red blood cells. Filgrastim increases white blood cell count. Oprelvecin increases platelets. Now, I want you to think about this. The last drug, epoetin alpha, filgrastim, and now oprelvecin. When might somebody have issues with their red count, their white count, and their platelets? Leukemia, right? When somebody has bone marrow problems, we're probably going to be giving bone marrow stimulating drugs, depending on where the cancer is, what the problem is, how bad it is, how bad the symptoms are, how low the levels are, or ineffective those levels are. So we want to be watching directly for too much of that drug's effectiveness. But yeah, leukemia is a great example. Maybe we're on a drug that is immunosuppressant. So not the cancer, but maybe some other drugs that we're taking decrease our bone marrow production. So we might need to take these drugs to increase those lab values to balance off the body's situation. And then chemo. I know that you may have mentioned a little bit about chemo last semester when you hopefully talked about it with the immune system. But I put these two drugs in here, 3 drugs in here, because I wanted to draw attention to their purpose for leukemia. So methotrexate is a chemotherapy drug that's often used in combination for acute LL and AML. So who is the population that would be getting this drug for ALL and AML? Children. Good. Right. So we need to be watching for, chemotherapy is nasty, and it's nasty on rapidly growing tissue, and children are full of rapidly growing tissue. So there's a lot of potential complications. Asparaginase. Now here's an ACE ending. Now this is not a thrombolytic enzyme. But it is an anti-neoplastic, again, for ALL, and then chronic, so elderly with the CML. Now, when you're looking at drugs, it's important that you look at commonalities and then look for uniquenesses. So the commonalities on this slide of your anti-metabolites, your chemotherapy drugs, are that they are renal and liver toxic typically. They are nasty. They cause issues with rapidly growing tissue like your mouth. So that's why you end up with stomatitis a lot, nausea, vomiting, and diarrhea, because the tissues in your body, they're really strong drugs. So there's some commonalities there. myelosuppression, which is, anybody know what myelosuppression is? As an expected adverse effect. And as soon as I say it, you're going to be like, oh, he just said that, but he used different words. Myelosuppression is actually bone marrow suppression. So myelosuppression is going to be causing the low red count, low white count, low platelets. Chemotherapy drugs do that. So that's a commonality there. And honestly, the one big difference is methotrexate has an antidote and asparaginase does not. So, and then there's steroids. Steroids are also immunosuppressing drugs, to some extent bone marrow suppressing drugs. And so they have some similar effects, but they're not quite as, I would say, potent in their myelosuppression. So that brings us to the end of the meds. I'm going to go ahead and stop that recording.